Thank you. Thank you so much. Bismillah Rahman Rahim. First of all, I would like to thank the organizers for giving me the opportunity to stand here and talk to all of you. I'm really grateful to Professor Tafazul and his team and all the RheumaCon organizers. So I'll talk about treatment strategies for rheumatic diseases in resource-limited settings. I'm Dr. Bilal and Head of Department of Rheumatology at FGMU. I don't have any disclosure, but there are several disclaimers I'd like to announce here. Firstly, all these treatment strategies that I'll tell you are expert opinions or suggestions. They may not follow the guidelines or recommendations that you read in books. And most of the patients are, all of the patients are actually real patients, and the scenarios are actually real scenarios that we face in public sector hospital like Fatima Jinnah Medical University. Next statement जो है, इसको ज़रा first I'll tell you a few learning outcomes. The first outcome will be to appreciate the mindset of treating patients not as disease but as a complete human being. Whenever we treat a patient, we should look at the patient as a complete human being, not just as a disease. उसकी disease को treat नहीं करना, पूरे के पूरे patient को और बंदे को treat करना है. Then the learning outcome is to understand the difficulties that arise while treating such patients. And lastly, to know suggested strategies in resource-limited settings, both in terms of access to care and treatment modifications. Last जो है, जब हम presentation बनाते हैं तो we are told कि आप येलो कलर और डार्क कलर्स यूज़ ना करें, वो आई के लिए बहुत इरीटेटिंग होते हैं. लेकिन मैंने स्पेशली ये कलर इसीलिए येलो में लिखा है ताकि आप सब लोगों की आंखों को इरीटेट हो कि दिस इज़ टू सजेस्ट दैट आवर सिस्टम वी शुड वर्क, जिसके पास जितनी पावर है, वर्क टू इम्प्रूव द सिस्टम in such a way that our patients do not have to rely on the second option for anything. Our system should not beg to follow the things which are not state of the art. So beggars can't be choosers. So therefore, we need to improve our system, improve our healthcare to reach at a level where we can provide state of the art treatment to every patient. So let's move on. I have a few cases. First case, she's a 55-year-old widow diagnosed as seropositive rheumatoid arthritis 10 years back. Came to our rheumatology OPD with flare of arthritis. She has many poor prognostic factors for rheumatoid arthritis. She has no siblings and her parents are not alive. She has one daughter who is married and she is homeless and never even made a national identity card. So look at all the problems that she has. These are her hands. So when she came to us, she was taking 15 milligrams of methotrexate per week with prednisolone and hydroxychloroquine. What modifications we did, we increased her methotrexate to 20 milligrams, gave her a short course of steroids, continuous hydroxychloroquine, and asked her to follow us up with the labs. On follow-up, she didn't get her labs because she was not affording for the labs. She was still hurting, RA was moderately active. She took medicine in adequate doses, but could not afford the labs. What should be done now? Fellows हमारे इसमें बताएं कि we gave her methotrexate full dose, she didn't improve. ये एक guidelines हैं. These are the latest guidelines by American College of Rheumatology which suggest that patients with poor prognostic factors, which she had, should go straight towards adding a biologic or a JAK inhibitor. If there are no poor prognostic factors, add a second conventional DMARD. She falls in this category. But there were several limitations. She was non-affording for biologics, JAK inhibitors, even for labs. She had no CNIC and no family support. फिर क्या करना चाहिए इसके साथ? हाँ. So what we did, इसमें option ये था, we added a second dose conventional synthetic DMARD like sulfasalazine or leflunomide and followed up the patient. These were not according to the guideline, but it was a feasible strategy for such patients. Now, there is a little data on this also. There is a trial, record trial that showed that non-inferiority of triple therapy compared to biological agents in terms of efficacy. Triple therapy was a first-line cost-effective option for patients who fail methotrexate compared to biological DMARDs. And this was the evidence. This was published in 2021. Another study shows that higher doses of methotrexate in combination with prednisolone or with another combination of DMARD like sulfasalazine or leflunomide reduces the percentage of patients that require biologic therapy. This was also published in 2014. So take-home message is, if the patient is non-affording, you can switch to you can add a second agent. This is not according to the guidelines, but evidence has shown that it can be efficacious and it can be equivalent to biologics. Now let's move on to our second case. A 37-year-old divorced lady has 2 children, comes from a family that does not accept zakat, developed Raynaud's, skin tightening, joint pains, epigastric pain, burning and dyspnea 3 years back. She lived in a village near Lahore and went to several local doctors for these 3 years, who gave her symptomatic treatment like NSAIDs and PPIs. When she came to us, she came with her mother, with whom she lived after divorce, and she had similar complaints. These are few of the pictures, not her actual pictures, but she had most of these findings. Unfortunately, she's not alive. She had skin tightening, ulcers, decreased mouth opening, Raynaud's. CT में क्या नज़र आ रहा है? फेलोज को बता सकते हैं? Bilateral ground glass appearance. So what does she has? A scleroderma with interstitial lung disease and NSIP, non-specific interstitial pneumonia. So she was given calcium channel blockers, proton pump inhibitors, and mycophenolate. So what happens? She comes back after a few weeks. She cannot afford mycophenolate. So she didn't take mycophenolate, told that it is too expensive. So she had poor medical compliance due to affordability. She was switched to azathioprine because it is a cheaper option. On further follow-up, she was taking azathioprine and steroids, but there was no improvement. So what can be done now? These are the latest guidelines. Aapne ILD ki, if you have read that, these are the guidelines of treatment of interstitial lung disease, first in systemic sclerosis. First line therapy is preferred and additional, and glucocorticoid low dose can be given. So, इसमें क्या limitations हैं? Compromise access. 3 साल से she was going to some local doctors near Lahore, but she was undiagnosed. Cost of medicine is an issue, and as she was not of a family that does not accept zakat, so Baitul Mal option was not also there, and she was of childbearing age. अब कोई आपके और we convinced her. She was divorced. She said that she is not planning to remarry, so we switched her to cyclophosphamide and gave her cyclophosphamide. She was much improved. Later on, she developed tuberculosis and other things, but her interstitial lung disease improved. And there is evidence, first of all, to how to improve the access of care. 3 साल तक she was going to local GPs but didn't improve. There was a study done which showed empowering of family physicians by training them in rheumatology can be effective tool to fight unmet needs. A statistical significant difference was found between the pre and post-course assessment of this program. This was done in Lahore by Dr. Saira and team and was published in 2020 in Clinical Rheumatology. So if they have done it, we can do it too, and we can empower our family physicians to improve the access to care. Now coming on the drugs, data shows that both MMF and cyclo were equally effective. In fact, cyclo is, I think, a little more effective in stabilizing lung function in patients with scleroderma-induced interstitial lung disease. The efficacy of MMF with respect to FVC and DLCO improvement is comparable to that of cyclophosphamide. Now let's move on to our case number 3. 22-year-old girl diagnosed with JIA. 3 years back, her illness started about 7 to 8 years back when she was 12 to 13 years old, but it was diagnosed just 3 years back with severe joint pain. When she came to us, she was already taking methotrexate 25 mg per week, hydroxychloroquine 400 mg per day, sulfasalazine 2.5 grams per day, and prednisolone 10 mg per day. She was compliant to treatment, but her disease was still active. इसमें क्या कर सकते हैं? वो वैसे नज़र आ गया था शायद. इसमें तो ये फुल हमने किया ये कि fortunately we got her enrolled in Baitul Mal and she got a Turnercept. She was given 50 milligrams per week through Baitul Mal. But हुआ क्या? She improved initially. But जैसे होता है कि जब गवर्नमेंट चेंज होती है तो फंड बंद हो जाते हैं. So the Pakistan Baitul Mal fund stopped. And she had limited number of injections. Now she started hurting again, and she came back to us. What can be done now? इसमें ये देख लें. These are the guidelines that show that if it is there is no improvement, you could add a biologic or switch therapy, इसमें हमने वैसे ये किया, पहले limitations देख लें. Limitation of funds, follow-up labs, because she was on biologic, she couldn't afford that. So what we did was that we increased the duration of the etanercept injections. जैसे पहले वो 50 milligram once a week ले रही थी, we increased it to 10 days. Or another option was that we can give her 25 milligrams of injection per week. So either reduce the dose or increase the interval. क्योंकि ऐसे था कि बैतुल माल से उसके इंजेक्शन बंद नहीं हुए थे, but if we were asking them to give 10 injections, they were giving 5 injections. So etanercept tapering can be done without losing efficacy in RA, psoriatic, and AS patients, and this was shown in a data in 2023. Patients with RA who have achieved low disease activity on etanercept plus methotrexate, continuing both is superior to placebo, and reduced dose was also more effective than placebo drugs. This was shown in a study in 2016. And lengthening of the treatment interval, जब हमने देखा, we found out this, that lengthening of treatment is actually better than reducing the dose of the drug. So when we thought कि उसकी 25 कर दें या 50 कर दें, so the better option was to give her 50 milligrams but increase the interval to gap the period in which the drug was not available. This has also been shown in a data published in 2015. Now our next case, this is the last case, 35-year-old male with psoriasis for 3 years, presents with arthritis affecting the large and joints and inflammatory back pain. He was started on methotrexate but developed transaminitis. They were sent to me, मैंने उसको low dose दोबारा start की, but he again had transaminitis. And then alternate was tried like sulfasalazine, he had a reaction to that. These are actual pictures of the patient. यहाँ पे इसके rash देखिए on the back, on the feet, on the legs. So he had real active skin lesions and arthritis was also active. इसको हमने थोड़ा सा convince कर लिया. He was a little bit affording. So he started secukinumab 150 milligrams subcut monthly without loading dose. आपके पास भी ऐसे पेशेंट आते हैं real time when you are limited by things और आप फिर कोई you try to find out a way where you can accommodate all the things. So we didn't load him, didn't give him 300 milligrams, gave him 150 milligrams subcut monthly without loading dose. He improved a lot, but he could only afford it for 3 months. Next year हुआ कि he lost his job, he was not affording for that anymore. So what were the limitations here? The cost and the drug side effects. इसमें हम क्या कर सकते हैं? इसने बैतुल माल से इसने भी कहा कि मैं बैतुल माल से नहीं कर सकता अफोर्ड. कोई और ऑप्शन है आपके पास? इसमें वैसे हम भी क्लूलेस थे. वैसे रिड्यूस डोज हो सकती थी और इंक्रीज इंटरवल हो सकता था. फॉर्चुनेटली और अनफॉर्चुनेटली ही was lost to follow up and has not come back. So the strategies here can be to either reduce the dose or increase the interval. Evidence has shown that 45.7% of chronic arthritis patients receiving low dose biologic therapy after achieving remission at standard doses do maintain a good control of the disease. And the feasibility and efficacy safety of gradually increasing the dosing interval. इसमें भी ये है, do not reduce the dose but increase the interval. And modified dosing schedule of secukinumab with gradually increasing the interval is still feasible. It was shown in a study published in 2022 in Dermatological Therapy Journal. Just an introduction, you should know that there is a huge impact of rheumatological diseases on the quality of life of the patients. There is a disparity, unfortunately, जैसे मैंने वो पहले वो show किया, there is a disparity between resource limited settings and the developed world. What are the constraints? High treatment costs, lack of infrastructure like inadequate facilities, shortage of rheumatologists. What approaches can be done? Education and awareness. Education of the doctors, awareness of the general public so that they know when to reach a doctor and which doctor to reach. And doctors can be educated who can go to far areas and practice rheumatology there and improve the patient's quality of life. Collaboration and partnerships. Several NGOs are there, pharma companies, we can ask the government agencies to do something to improve the collaborations and partnerships in order to improve the access to care and improve the availability of these drugs to the patients. Telemedicine is a very good news that has came up in the COVID era. We can practice telemedicine in rheumatology, like tele-rheumatology. APLAR has also published guidelines on that. In that way, a patient in a far area can be linked to a doctor here in big cities, and treatment and advice can be provided. Affordability and accessibility can be improved by stressing on the government or the companies or the DRAP to have a control of the drug pricing. And we can do community-based clinics to improve the accessibility of the patients. Teams can go to different communities and detect and diagnose patients there, and then call them up in tertiary care setups to improve early diagnosis and improve quality of life. From my point of view, from my side, few strategies that I can recommend are, you can combine DMARDs instead of giving a biologic agent or a JAK inhibitor. You can use cheaper and effective alternates. You can increase the interval or reduce the dose. थोड़ा सा data मैं बताऊंगा in FGMU. We see about 300 to 400 to 500 patients per month. Most of them are from low socioeconomic status. Most of them cannot afford expensive drugs and biologics. So what we do, we have Baitul Mal service there, we use that, or we have several NGOs or other things we can do that. There is a success story which I want to share with you, which is Arthritis Care Foundation. It is a good foundation. It is a success story of giving treatment to patients and improving access in resource-limited settings. I am honored that my training was also sponsored by Arthritis Care Foundation, that I am here in front of you and telling you all this. So we can do a lot of things to do our part in these things, in improving the care. So what are the take-home messages? Know your patient as a whole, identify the constraints, decide treatments keeping in mind all the factors, work to increase the awareness and education, plan to modify and adjust, do not stick to guidelines or do not be too strict in treatment options. And lastly, be the one to make the change. You can make the change. You can find out things. You can make NGOs or some other things which you can do to improve the access and make patients' life easier and improve their quality of life. And this is a memorable picture when we inaugurated our rheumatology department at Fatima Jinnah Medical University. इसमें कुछ लोग हैं which are really my mentors, like Professor Faisal Masood, Professor Nigat Mir, and all the team, Professor Sajid Nisar, Professor Sumaira, Professor Ahmed, सारे लोग. It was a memorable day for FGMU when this was done. Thank you.